Good evening, everybody, and thank you for attending. We're just giving everybody a quick chance to register, so we'll probably start in about half a minute. So we're just letting everybody join us now on the webinar. That's great. So I can see lots of people coming in now, which is great. And welcome everybody to this lecture series, this lecture this evening. So my name is Eileen Gibney, and I'm the director of the Institute of Food and Health, and I'm delighted to welcome you to the final talk of the public lecture series in 2024. I can't believe 2024 has gone so quickly. So the purpose of these lectures is to provide you with the most up-to-date scientific knowledge in the area of food and health and topics that are of interest to you. So tonight's lecture is in the area of bone health, and with the large number of people we've registered and those coming in to join us now, we know this is a really important and interesting topic for you. So I'm going to introduce our two speakers this evening. We've Professor Caitriona Cunningham and Dr. Aifric O'Sullivan. So Caitriona is an associate professor in physiotherapy at UCD, and she teaches on the professional physiotherapy programs. She's also practiced clinically for several years and specializes in musculoskeletal physiotherapy. With her colleagues, she's led the Better Bones Exercise and Education program in UCD, which focused on empowering people to engage in bone building behaviors, including exercise and diet. And Caitriona also works with the Fragility Fracture Network, an international network that conducts research and develops guidelines to manage fractures associated with osteoporosis. Aifric is an assistant professor at the School of Agriculture and Food Science, and she's also our VP for International in the College of Health and Agricultural Sciences. And her work focuses on personalized nutrition, and she leads projects in the areas related to both sustainable health and vitamin D. And she's going to talk this evening about the role of nutrition in bone health. And we'll touch on some research about vitamin D prevention in wintertime, which is coming up now. So during the talk, if you have any questions, you need to add them to the Q&A tab that you'll see at the bottom of the screen. And at the end of the lectures, my colleague, Professor Lorraine Brennan, will moderate the questions and answers section. So really looking forward to hearing from you, any questions that you have or you wish to answer. And I'm delighted to hand over to Caitriona and Aifric for your talks. So thanks all for attending, and I look forward to hearing all the talks.
Thank you. People see that, yeah?
Yes, we can, yeah.
Great, I'll get started. So hello everybody, and welcome to our webinar this evening. I'm Caitriona Cunningham, and I'm based at the School of Public Health, Physiotherapy and Sports Science, and I am a CORA-registered physiotherapist myself. Just moving along here. So I suppose sometimes I'm not surprised when so many people are joining this lecture on a Monday evening. And the reason being that, you know, a lot of people are going to sustain a fracture due to osteoporosis. And depending on where you read, that's anything from 1 in 3 women over the age of 50, and between 1 in 4, 1 in 5 men over the age of 50 are going to sustain a fracture due to fragile bone or osteoporosis. And the most common fragility fractures are at the wrist, the hip, or the spine, but also can affect shoulder area and the ankle, and also foot fractures. So this evening, I'm going to talk to you a little bit about bone health across the lifespan, talk a little bit about, and again, this is a bit of a tongue twister, bone building behaviors, prevention of osteoporosis, and then touch on exercise for people who actually have been diagnosed with osteoporosis. As I say, I'm a CORA-registered physiotherapist. I've been conducting research in the area of bone health for some time, and I'm part of that international group that's looking at fragility fractures. It's a number of different disciplines, clinicians and researchers coming together to try and really prevent fragility fractures and look at the management of them as well. So looking forward to our talk this evening. I suppose the first thing to say, many of you are already aware, bones are a living tissue. So in saying that, you know, it's not an inert structure, just this hard structure. They're living, and basically our bones have a blood supply. They have a variety of cells, a variety of proteins, lots of signaling, chemical signaling happening. Our hormones can influence our bones. And again, we can do a lot to influence our bones. And I suppose it's just important to say that. We can also run simple blood tests that can be run with people to show whether they're absorbing more bone or laying down bone. And you can see one or two tests there, the CTX or the P1NP tests. So these are just blood tests that are done to see whether how our bone turnover is. And what I mean by bone turnover is that our bone is constantly remodeling, and we have different types of cells producing new bone, and we have cells that are munching away and eating away at our bone. And now this is a very simplistic representation of this, but basically the osteoclasts are the main cells that are kind of eating away at our bone and resorbing it. And then the osteoblasts are producing new bone and laying it down. And that's on the go all the time. And we seek to influence that, and we influence it in different ways. This can include our diet. It can include, hormones, as I say, but also exercise. And bone responds to mechanical inputs. So the mechanical input that we give to our bone through exercise or just our everyday activity. And again, you'll hear of, astronauts going to space and that they have to mind their bone density because they're not getting that gravity exercises, which they do try and engage in to combat this, similarly for their muscles. Now, we think about bone health across the lifespan. Bone health, really, we can start to influence it during pregnancy. The diet of the mother will influence the bone development in the unborn child. And then in the early days of a baby's life, if the baby is being breastfed, we need to supplement with vitamin D to ensure the bone growth is good in that child. And then during our childhood years, we're building up our bone mass, and we keep building up our peak bone mass until we reach about the age of 25 to 30. And the men hit peak bone mass a little bit earlier than women at around age 25 and around age 30 for women. And then as we continue through life, we have a period of fairly static bone mass, and then quite a dip occurs for women at the time of the menopause. And that's because our estrogen levels drop. And so depending on when menopause happens, you'll have that drop in bone mass, and it's more gradual for men. I suppose the big difference now is that in general, people are living a lot longer. So the bone that we're born with and that we build to peak bone mass has to last us a lot longer, hopefully, and may have to last us past 100 years of age. And that's probably why you're hearing way more about osteoporosis and about people fracturing, apart from the fact that people are actually having osteoporosis diagnosed and scans being performed for bone density. Similarly, we're going to talk about the muscle because we can't separate the two, really. Our bones respond to, the input of our muscles and the force that our muscles place on our bones. So after age 30, people begin to lose as much as 3 to 5% of their muscle mass per decade. So you'll see an image there of, we'll say, a 30-year-old arm with nice bulky muscles. And these, decrease in size as we age, and you can see that image there. The second set of images there is looking through the thigh muscles, and you'll see again a bulkier age 25 muscle, and then this shrinking as we age to our 60s, where you may even have fat infiltrating the muscle. Then as people age, we don't automatically, but generally we're going to maybe develop sarcopenia. And sarcopenia really isn't just the normal aging process, it's more accelerated, where the muscle disease with loss of strength is a key feature. And there's a lot of debate over sarcopenia and what it means to have sarcopenia, but newer definitions would say it's when you have low muscle strength, there's a low muscle quantity or quality, and your physical performance and ability to use your muscles has changed. And it's associated with aging, but also many other factors. But it's important because our muscles influence our bone. Now, again, I suppose it's important that we consider what is osteoporosis. Well, looking at the image there on your screen again, you can see that normal bone has a honeycomb structure inside and looks a little bit like a crunchy. And then you can see that's normal, where it's fairly dense on the left. And then as we age, we will lose some of that density. But if you become osteoporotic, you'll see that the gaps in that increase, and the struts between those have got thinner and finer. and our bone has become more fragile. And many of us here on the call may have fragile bone. We may not even know if we haven't had a scan. But basically, there's no pain associated with that. The issue is if we have an incident, which could be something very simple, like a simple slip or a trip, the incident may cause our bone to fracture if it's fragile. And that then is what's known as a fragility fracture. So I suppose everybody wants to know, well, what are my chances of getting osteoporosis? And when we talk about risk factors, we're saying, you know, what puts me at greater risk of getting a fracture or getting osteoporosis rather? A family history, you know, you may not know, did your parents or family members have a fracture due to fragile bone? Did they have a simple trip or a fall or an incident in their 50s, 60s where they fractured? White and Asian people are at higher risk of osteoporosis. Low body weight is another risk factor, and obviously a history of fractures as well, or not obviously, but a history of previous fracture, not due to major trauma. Other risk factors, particularly in women, many of these are related to lower estrogen. So an earlier menopause and then having longer for your bone to last following that menopause, early hysterectomy, or people who've missed periods for 6 months or more, excluding pregnancy, obviously, but as a result of over-exercising or over-dieting. So again, that's, you know, where the period stopped due to a lack of estrogen, and this will have an impact, a negative impact on bone mass. Many medical conditions can affect bone mass. I'm just touching on some of the common ones we know affect bone mass. Rheumatoid arthritis, the disease itself, and the steroid treatment could increase the risk. Eating disorders, where we're not getting the adequate nutrition to support our bone. Where we have gastrointestinal disorders, in other words, disorders of the digestive system like celiac disease, Crohn's disease, primary biliary cirrhosis, where we're not going to absorb the nutrients. Endocrine or hormonal issues, and that covers a lot, I know, but chronic kidney disease and diabetes, these are some of the other common conditions that can affect our bone mass. Some medications can increase the risk of osteoporosis. Again, the steroids, some blood thinners, or known as anticoagulants. Chemotherapy for cancer, DEXA scanned, and be checked for bone density if they're going through cancer treatment. Lifestyle factors. If we don't have the regular exercise, calcium, vitamin D, a lack of that, too much stress, smoking, too much alcohol, excessive exercise, particularly if not getting enough food or caloric intake, and excessive salt or caffeine. Now, how would I know I have osteoporosis? Well, unfortunately, many people don't know they have it until they have a fracture. And as I say, a fragility fracture is one where you think it wasn't the extent of the trauma that caused the fracture, but a fall from a standing height or less are a sign of underlying osteoporosis. So if somebody just has a simple fall off a step or a simple fall from standing height and they sustain a fracture, one would be thinking that maybe there's osteoporosis and that needs to be flagged. Similarly, this could be a spinal fracture, a vertebral fracture. And if it was an older person, and now I don't mean older, but in the sense of age 65 plus, a physiotherapist, we would look out for that person. It could be a number of things, but if someone had a sudden onset of severe, very specific low back pain, age 65 plus, and they didn't have a history of back pain, we'd be thinking, well, perhaps this is a vertebral fracture. And again, this would need to be diagnosed by X-ray or DEXA. There's a whole movement to capture the fracture, basically saying if that person at a younger age, maybe in their 50s, maybe a little bit older, if they have that first fracture, we need to be thinking, does something need to be done to manage this person, to diagnose osteoporosis and see if it's present, and then to initiate treatment. So don't wait for the hip fracture is the key message. If you've that wrist fracture or a spinal fracture or a simple ankle fracture, you want to start doing something about your bone health. You want to start checking and seeing if you have osteoporosis. Another tool that's used by clinicians is your FRAC tool. And again, this is to try and predict, what are your chances of having a fracture due to fragile bone in the next 10 years. You'll probably have heard of people having DEXA scans. Again, it's the gold standard, the best way really of determining what your bone density is like. And again, if you have a DEXA scan, it's a good idea, to know that you're going to an experienced scanner where possible. And if you're going to repeat DEXA scans every 3 to 5 years, you would try and go to the same place, not always possible. And I suppose really the recommendation is over the age of 50, 55 for women to consider having a DEXA scan, a little bit older for men. But certainly after the menopause, women should start thinking about it and discuss it with their GP and see, should they consider having a scan. Now, when you have a DEXA scan, you'll be given a T-score usually. And the T-score is where your bone mass or density is compared with the peak bone mass of an average 30-year-old of the same sex. So basically, depending on what your bone is like, you'll be classified as having a normal bone density. And if you're moving away from what the bone was like of a 30-year-old, you might be osteopenic. And if your T-score then is going to minus 2.5, you'd be osteoporotic. But these are not absolute numbers. They're basically saying, how do you compare to other people in the population? If you're diagnosed with osteoporosis, there are lots of good medications, and the recommendation is to initiate treatment, but that's a discussion to have with your GP. You may seek a referral to a specialist like a rheumatologist or an endocrinologist. But some of the medications, they'll either slow down the cells that break down bone, or they'll stimulate cells that build new bone, or it'll be a combination of both. I'm just going to scan through some of the medications here, and you can look at these slides again. There are those that are the bisphosphonates is one category, and I'm not a pharmacist, where they really try and stop the bone being resorbed. And some of those are the brand names there. Some of them are delivered, just taking a tablet. Others are a nasal spray. And then there's another category of drugs, which are where you inject it every 6 months, like a Prolia injection. And then some would be related to having hormone replacement therapy, in other words, estrogen therapy. Other osteoporosis medications are for the more severe osteoporosis, and they're really trying to trigger bone formation. You might have a daily injection for someone who's had maybe a vertebral fracture. And by a vertebral fracture, we mean a fracture in your spine and due to osteoporosis. So lots of ways we can influence our bone. Medications is just one way, and you do not need medications unless you're diagnosed with osteoporosis. Other ways are diet and supplements, and Dr. Sullivan is going to talk to that. So I'm going to speak more about exercise. So as I said, peak bone mass, we're going to hit that around age 25 to 30. So our last chance, and I think this is an important message to get across to your children, to grandchildren, that basically you have a chance to build your best bone mass by exercising in your young years and by getting the appropriate diet. So osteoporosis isn't something, the thoughts of which you should push off much as we'd like to. If you're active as a child and engage in active exercise, you're more likely to have good bone. And impact exercise would be things like basketball, volleyball, jumping, skipping, but all exercise where the muscles are being used would have impact. What should you eat? I'm going to hand over to my colleague to speak to this in the next lecture, so I'm going to move on from that. And in terms of exercise, when people are young, we're talking about trying to build to get that best peak bone mass. In the middle years, we're trying to talk about really keeping what you have. And then in the later years, you might not be able to build more bone, but you might be able to slow down the bone loss. Or your focus might even be on, how can I keep my function so that I don't actually have a fall, and that I obviously keep my function for other reasons as well, my physical function. Now, what type of exercise is best to build bone? Well, we know that bone responds to mechanical stimuli, and the more unusual these are, the better. So something that causes, a sudden high strain and an unusual strain distribution. In other words, where you're doing a strength training exercise or you're doing a high impact exercise, these are the way to go to build bone. Impact exercises for the lower limbs, your legs or your spine, might be skipping, star jumps, step-ups, hopping, jumping, jogging, stepping, running. For your upper limbs or your arms, it's a little bit harder. Push-ups, clapping, punching. And the evidence is saying you need a diverse exercise routine. Walking. Now, walking is good for health. Walking is good for your bones, but you may need to do more than walking, is what the evidence is saying. That said, if you have spent a period in bed for any reason due to an illness, or you're not walking regularly, walking will stimulate your bone. But if you're a regular walker, you may need to do a little bit more to stimulate your bone, to give that additional stimulus. And this is just an interesting paper here by Sherrington et al. When they did a study with frail people and they want them brisk walking, you even have to build up to brisk walking for some people who are not regularly taking exercise. And a number of people who were older actually fell when they embarked on a brisk walking program. So even for people, if they're frail and not walking regularly, they need to build up gradually to regular walking and then building up the speed and then stepping a little bit harder. We talk about strength training, resistance training, and we know the evidence is showing that high force exercise with strength training is good for the lower limbs, it's good for the spine. And the more recent evidence is really saying maybe we need to load a little bit more. We need to get the muscles working a little bit harder. So not just light weights, but obviously if someone is starting an exercise program, they've got to start in maybe the endurance sewing, doing maybe lower weights and higher numbers of repetitions. And then as they get stronger, they can build up the load. This was a study from Japan from about 15 years ago, but it's interesting because not as much research has been done on these spinal exercise since. But certainly the exercise routines should include exercises for the spinal extensors. In other words, the muscles on our back that would allow us to lean backwards, and the Pilates type exercises, although not all Pilates is going to stimulate bone growth, but if there's a muscle pull, it will. So I suppose the message really is that mixed loading is the way to go. And by mixed loading, we're talking about a mix of strength training and also impact exercise. This most recent paper, was trying to distinguish, was there a difference between the different types of exercise and the effects? It was hard to draw concrete conclusions. We know resistance works, we know impact works. All types of exercise will have some effect, but it seems the mix is the best. Now, how much effect do you get with exercise? Well, it is disappointing sometimes that when you rescan people, sometimes the difference in bone loss is only 1 to 3% less in those that exercise. So that can be a little bit disappointing for people to see, but we need to realize the other benefits of exercise also are about reducing the risk of having a fall or a trip or a slip. And again, people sometimes think that's all older. I surveyed the students, straw poll in class, and, 1 in 3 of our students will have fallen in the last 6 weeks or slipped or tripped. So again, lots of people fall, but the consequences are more serious if you have fragile bone. With any exercise program, we want to think about how often do I need to do it, the frequency, how hard do I need to push myself, for how long, and what type of training. Most of the studies that have shown a positive effect on bone have been for 12 months or greater duration. And they found that those who got better effects exercised 2 to 3 times a week versus once a week. So exercise is good. And I think that's a message we really need to get across. Irrespective of what illnesses you have, there's always an exercise. And even if you have osteoporosis, and people become very fearful, and we know this from running programs, but the benefits outweigh the risks in general. There are some precautions if you have more severe osteoporosis. You want to look at someone's fracture history, how severe is their bone density, and are they at falls risk? Like if someone has had a vertebral fracture, a spinal fracture due to osteoporosis in the last year, they have a much higher risk of another fracture in the subsequent year. But it is important to consult with a health professional to discuss and get started on your exercise, but ultimately move to exercising independently. That said, thankfully, more recent researchers are beginning to push people with osteoporosis a little bit more. And they're saying, hang on a minute, are we being overcautious with people with osteoporosis? Now, this is just one study, but it is nice to see that they were able to conduct this study with people who had osteoporosis, and they could actually get them lifting higher weights, which will impact positively on the individuals from both a physical function and a bone point of view. So it's promising, but we still have to exert caution. Another study there, again, looking at strength and balance, and this training can be done with people with osteoporosis and people who've had a vertebral fracture and bring about positive effects. Another study here, exercise can improve physical functioning and quality of life, but people are less sure how much change are we bringing about in bone that's osteoporotic. So if you're young and healthy, your exercise will have a big impact on your bone. If you're osteoporotic, you'll have some impact on the bone, but you may be looking for changes on your muscle and your physical function more so, and on reducing falls risk. We also need to be careful. Can you get people doing high impact exercise? If they have pain in their hips and knees, this is difficult. Or if they have more severe osteoporosis, it's challenging. And if you have pelvic floor issues or incontinence, that presents issues for both men and women. The Canadian guidelines are saying very much go to an exercise professional if you've been diagnosed with osteoporosis. In Ireland, that's going to be a physiotherapist who's prescribing clinical exercise as opposed to exercise for the general population. Things to avoid if you have severe osteoporosis: avoid that repeated bending of your spine, and particularly if you're carrying a weight or a load. Sit-ups not a good idea, cross-country ski machines, rowing machines. Again, that lifting, loading, bending down to the oven, lifting the Christmas turkey, not a good idea. Use the leg muscles, safe lifting techniques. Avoid sports that twist the spine, and that's a challenge clinically because people want to continue their sports. So I would never say never, and you need to make a shared decision with your patient and weigh up how much it means to them, coupled with the risk, and we don't know the absolute risk. This is just to say that we ran a Better Bones program at UCD the whole way up to COVID, actually, and over 7 years. And, you know, what we learned, I suppose, from that was that some people came thinking that they could do exercise as an alternative to medication if they had osteoporosis, but that's not wise. If you have osteoporosis, you know, the medications do work. Obviously, it's an individual choice, but the evidence would support taking medications if you have been diagnosed with osteoporosis. And again, there is a whole dietary piece we're going to address in our next lecture this evening. We also wanted to empower people to become independently active, and people really enjoyed that aspect, but it took them longer than the 6 weeks to get confident about increasing the load in the gym. And some people lost confidence because they didn't realize the consequences of osteoporosis. So initially they actually lost confidence. So we had to go with a longer program to build up that confidence again so that people would remain active. So I suppose my takeaway messages are the best exercise is good. If you want to improve your bone, you need to do strength training and impact, so mixed loading programs. In terms of your muscle, if you have sarcopenia or you just want to keep your function, strength exercise again. And if you want to prevent falls, it's strength exercise again. So strength training is really important across the lifespan. Balance training will also help prevent falls, and impact training will also help your bones. Thank you very much.
Thanks, Caitriona. I'll just take a second here to switch over. 1 second. There we go. We should be looking at that now, yeah? Okay. So, essentially, I am going to carry on from where Caitriona left off, but focusing on diet, really. 1 second, sorry now. Trying to organize my slides here. All right, so as I said, touching very briefly on a couple of points that Caitriona already mentioned, and really just to be able to flag where nutrients have important roles. And then I'll go into kind of looking at, well, what are the foods and how much of these specific nutrients do we need to include in our diet. After that, kind of the second half of my presentation, I'm going to focus on vitamin D for a couple of different reasons. Number one is it plays a really important role in bone health, obviously. The second thing, though, in Ireland, we're particularly bad about getting enough vitamin D in our diets. And now is a particularly critical time of year when we're really relying on vitamin D in foods. And then lastly, for the very reason that it's just a big component of my own research, and just wanted to highlight some of what we're doing here in UCD for you. So, as I said, touching back to the basic bone physiology, Caitriona already described the different types of bone and bone development, but just to mention, we have this kind of mineral component of bone, which makes up about 65% of our bone, and then a protein component or a protein matrix, which makes up about 35% of the bone. And again, Caitriona did kind of show you a much nicer figure than this, but really just highlighting that the 3 phases of bone development. So we have the growth phase up to the early 20s. We've that kind of modeling and consolidation phase where we're not seeing major changes in length, but we are seeing that bones are continuing to change shape and thickness, and particularly when stressed. And Caitriona was using the example of exercise or strength training as a type of bone stressor in that case. And then lastly, we have the remodeling phase. And what we see there is that we have both breakdown information happening all the time, but towards later adulthood, we see that breakdown tends to kind of outweigh the formation, and you see this gradual decline in bone mass again, as Caitriona had described. The reason I'm highlighting these phases here is because they really do show that there's certain critical phases across the life cycle that we really need to focus on food intake for healthy bones. Okay, so what nutrients play a role? Well, I'm sure you're all familiar with the fact that calcium and vitamin D are really important, but you can see from this list, there's several other nutrients that play important roles. And these are just micronutrients. I haven't listed all of the nutrients here. For example, we still do need to make sure we're getting enough protein in our diets. And there's also evidence to show a relationship between omega-3 fatty acids and bone health too. So I want to go through some of the functions of these nutrients. I won't have time to go through each individually, but I'll just talk about, well, how much do we need? What is their function with respect to bone health? And then kind of what foods do we get these nutrients from? And as I said, I'm coming back to vitamin D, so I won't include that on these 2 slides. So calcium is an easy one. It's a major structural component of bone. And as we saw kind of earlier in the presentation, if we don't get enough during childhood, it means that a child might not meet their peak kind of bone mass. Whereas kind of later in adulthood, we're kind of relying on getting calcium in our diets so that we don't kind of accelerate that rate of bone loss. Dairy foods are an excellent source of calcium. So we get between 300 and 400 milligrams of calcium in 1 serving of dairy. And you can see our target intake for calcium in our day-to-day diet is between 950 and 1,000 milligrams per day. So if you were consuming 3 servings of dairy foods across the day, you'd be reaching your target. Other sources are things like canned sardines and green leafy vegetables, which will also count towards your total calcium intake. Phosphorus is another really important structural component. It combines with calcium to form that mineral crystal hydroxyapatite, which I highlighted in the first list of nutrients. Again, dairy foods, meat and fish are all excellent sources, but we can get some phosphorus from whole grain breads, and some fortified cereals are good sources too. Magnesium is another mineral that has an impact on that kind of hydroxyapatite component, or the mineral component of our bones. And things like spinach, brown rice, and almonds are all really good sources of magnesium. So again, we think of bone health, and if we're thinking of vitamins, we probably immediately think of vitamin D. But I just want to draw your attention to some of the others. So things like vitamin A, vitamin C, and vitamin K, which we might not be familiar with as being connected with bone health. But essentially, vitamin A is a vitamin that is needed for all growth, so bone or muscle, just growth in general. There's 2 forms of vitamin A in our diet. One that we get from animal source foods like meat, beef liver, or any type of liver is a really kind of rich source of that preformed vitamin A. And then we also get vitamin A from other sources, and these are from things like called carotenoids, which we get in brightly colored fruits and vegetables. So things like sweet potatoes, carrots, and peppers. And then next is vitamin C. We need vitamin C for synthesizing collagen, which is the protein part of the bone that we mentioned. We probably, again, are quite familiar with vitamin C, and we get a lot from citrus fruits, but we get vitamin C from other foods. So things like strawberries, kiwis, and again, peppers are really rich sources of vitamin C in our diets. And then the last one I've mentioned is vitamin K, and we need vitamin K for several different proteins that are connected. So we need them for the protein to function correctly. And we get vitamin K from things like dark green leafy vegetables, so particularly kale and spinach being really rich sources in our kind of day-to-day diet. So that was a real quick snapshot of some of the nutrients connected to bone health. But generally, if you kind of look at the overall picture, you can see that a kind of a well-balanced diet that includes plenty of fruits and vegetables and whole grains is really good for bone health. It is definitely important to prioritize calcium and vitamin D. And things like dairy foods and leafy greens can be good sources of calcium, as I mentioned. We also do need to make sure we're getting enough protein in our diet, and typically we are. So protein intake is usually not a problem. But then one that could also be considered is our omega-3 fatty acids, and I mentioned them separately. So things like EPA and DHA that we get from oily fish or sometimes from supplements, we also see an association with bone health. But really all of these bullet points are just components of our healthy balanced diet, and they would be components of the healthy eating guidelines that we have here in Ireland. So if you're following that kind of a healthy balanced diet, you can be generally kind of safe with respect to bone health. But with that particular focus, I would say, on calcium and again, vitamin D, which I'm going to come on to now. So I've mentioned a couple of times, obviously, I just want to kind of firstly focus on its role with respect to bone health. So vitamin D essentially helps to maintain our blood calcium and phosphorus levels. And there's very clear evidence for a link between low vitamin D and poor bone health. And we also know that if we combine calcium and vitamin D supplementation, we can reduce the risk of bone breaks and other kind of bone health issues, particularly in older adults who tend to be at higher risk, given that gradual decline in bone mass that we both spoke about. I also mentioned at the start of the presentation that now is a particularly good time to focus on vitamin D, and that is because between November and March, we have very little sun exposure in Ireland, and so we can't make vitamin D essentially between now and kind of mid to end of March, and that means that we're relying on our diet for all of our vitamin D intake. And we tend not to really be good at including those vitamin D rich foods in our diets day to day, so it can be a problem. The image here, firstly, is just to highlight that fact of what happens generally during winter months. So it's taken from a large national study of older adults in Ireland. So there was over 5,000 adults involved in the study. And the colour guide indicates the proportion of the population that have vitamin D levels lower than the cutoff that defines sufficient. So what is really concerning is that for almost half the year, about half of the population is not at the level that we'd like them to be. And although this is older adults, we know that it's similar for other life stages too. Okay, so how much do we need to get? Well, on the right-hand side, I've listed a couple of different dietary recommendations, and that's because there are different recommendations for different age groups. The recommendation for adults is 10 micrograms of vitamin D per day, but for babies and preschool children, it's 5, with mandatory supplementation for babies up to 12 months, and a recommendation for all preschool children to get a daily supplement between Halloween and St. Patrick's Day, so essentially between November and March. The two higher cutoffs are for older adults. The recommendation is that adults aged 65 and older take a vitamin D supplement of 15 micrograms every day to ensure that they get enough vitamin D that they need for bone and muscle health. And for those that are housebound with very limited sun exposure, they're recommended to take 20 micrograms of vitamin D per day. On the left, you can see the food sources. So you can actually see that a limited number of foods are naturally rich in vitamin D. So the good examples, I mentioned liver with respect to vitamin A already, but it is also a very good source of vitamin D as well. Oily fish and eggs are two other good natural sources. But we also can get some vitamin D from fortified foods. So certain milks are fortified, certain spreads are fortified, and certain breakfast cereals are fortified with vitamin D. So these can also add to our kind of day-to-day intake. This picture just shows the amount of vitamin D that we get from certain foods and how it relates to our requirements. And so just to keep in mind, the image here is relating it to a requirement of 15 micrograms per day and not 10 micrograms, which is our own recommendation for adults here in Ireland. So as you can see, the fish in this example had the highest amount. For those not familiar with bloater fish, it's very similar to herring. Salmon is another example where we get about 15 micrograms per portion also. So again, a very rich source of vitamin D in our diet, but we don't tend to eat it every day. And so again, that's why we're relying on other foods. Fortified breakfast cereals and eggs, as shown in this example here, have about 3 micrograms per serving again. And these are foods that we're more likely to consume day to day. So that brings me to our own research, and I'm going to just do a kind of a short synopsis of a couple of studies that I have been doing here in UCD, both funded by the Department of Agriculture, Food and Marine, and done jointly with collaborators, both Chagask and UCC. And these are called the NutriPlus and the Vitamin D DPI projects. This vitamin D research is essentially looking at how we can improve vitamin D in Ireland, and in particular, how we can prevent that wintertime vitamin D deficiency. So one way to increase vitamin D intakes is to fortify foods. And although we have voluntary fortification practices in Ireland, which means that companies or food manufacturers can decide to add vitamin D to certain food products, in other countries, some of them have mandatory fortification. So they might have a mandatory fortification of wheat flour or bread or milk, or sometimes a combination of foods. And so the first thing we wanted to do was to see, well, what would happen if we implemented a similar kind of a mandatory fortification policy. And so we kind of modeled this essentially. So we took existing dietary intake data from the National Adult Nutrition Survey, and we essentially calculated what would intakes be if we fortified different combinations of foods. And so this slide is a little bit complicated, so I'm just going to focus on some of the take-home messages. Looking at the figure on the left, I've highlighted the number 2 scenarios on the top and middle segments of the figure. And you can see these are kind of fortification scenarios which resulted in the highest intakes when we were just fortifying milk or just fortifying bread separately. So you see that intakes on average would be about 16.4 micrograms for bread and about 10.2 micrograms for milk. And this was when we were adding 1 serving of fortified bread to somebody's kind of day-to-day diet, or 1 serving of fortified milk to everybody's day-to-day diet. However, in these scenarios, we're adding extra bread or milk to someone's diet, and that's not ideal, because essentially we're also adding energy in that case, and we don't necessarily want to do that. So the best case scenario was actually when we replaced it. So in doing that, we had to swap out the bread and milk in people's diets and add in fortified. And our best case scenario for that was when we did that in combination. So when we kind of added the bread and milk swaps into people's diets, you can see it where I've highlighted scenario 5. We saw that we could increase people's mean daily vitamin D intake to 15.2 micrograms. Okay, so what we're seeing from that essentially is that mandatory fortification in theory can work, but the next step is to test if we can improve vitamin D levels by asking people to actually consume fortified foods. So we started with a dairy drink fortification study. And so to do this, we recruited healthy adults and we divided them into 4 groups. 3 of the 4 groups were getting 20 micrograms of vitamin D per day, 1 in a supplement form, and 2 of the groups were getting dairy drinks, essentially a milk drink, but they just had different fat components. And then our 4th group was the control group, and they had just an unfortified dairy drink. So participants took their drink or supplement every day for 4 weeks, and we measured the effect on vitamin levels. And so the main result was that we saw clear improvements in vitamin D, and we would have expected that in anyone who was taking the vitamin D supplement or drink, obviously. So much so that 94% of participants who were consuming a vitamin fortified dairy drink or supplement were actually classified as sufficient at the end of the study. So that was a really positive effect. The other very clear result was that anyone who started out with low vitamin D at the start of the study, and if they were in one of those vitamin D groups, they responded much better than those who started out with vitamin D levels that were in the kind of okay range. And then lastly, just to note that the fortified dairy drinks were as good as the supplement in increasing vitamin D levels, meaning we can rely on fortified foods to meet intakes and improve vitamin D levels as long as these foods are part of a person's day-to-day diet. So next up is the bread test, and this is pretty good timing because we've actually just started to recruit participants for this study just this week. So if you're over the age of 65, or if you know anyone over the age of 65 that might be interested in taking part, please take down the details or share the details. It's vitamindi@ucd.ie is the email address, or it's a Dublin phone number 716-2467 if you would like to take part. I should note that this study is in connection with the vitamin D research group in UCC. So we will be recruiting participants for the study in Dublin and Cork. So in this study, it's a 10-week study where you'd be allocated to one of just two groups, either a vitamin D fortified bread or an identical bread that is not fortified, and that's our control group. So you'd be asked to eat 2 slices of bread every day, and you'd be encouraged to continue to eat your vitamin D fortified foods that are already part of your day-to-day diet. We'd be asking you to come into the study centre in either UCC or UCD twice, once at the start and once at the end of the study, where we'd collect a small sample of blood and we'd ask you questions about the vitamin D foods that you're eating. So I suppose because we have that visit to the study centre, it does mean that you need to be within commuting distance of UCD or UCC. And really our main aim here is to see if we can prevent that usual decline that we see in vitamin D levels in these winter months. So that kind of takes me to my last slide. I just want to finish off by summarising some of the key results from this work and the take-home messages for moving forward. So essentially a healthy balanced diet will provide the right mix of nutrients for healthy bones, but we should also look to prioritise calcium and vitamin D rich foods. In Ireland, vitamin D deficiency rates are high, particularly in winter months when we have very little sunshine, but also because we're not getting enough in the foods we're eating. And based on our data modelling, it seems clear that we can reach vitamin D intake recommendations with food fortification, and fortifying a combination of foods will likely be more effective than one food alone. All that combined, I think we can conclude by saying that there's strong evidence for mandatory fortification. Fortifying dairy foods works, and next we're going to look to see what might happen if we fortified bread alongside that. So just to say thank you and acknowledge the two research teams, I suppose, that